Welcome to the GeriPal podcast. This is Eric Wadera. Alex, I think it's your turn.
I was reading song lyrics. This is Alex Smith. That was probably the most awkward introduction we've had yet.
We're getting
worse at our introductions.
Maybe slightly delirious.
Maybe.
Today.
Where am I?
What
is the date?
We have a guest who's going to be talking about delirium today.
Yes,
right?
we do have a guest. We have a guest on the Skype line. We have Tim Girard, who is Associate Professor of Critical Care Medicine at the University of Pittsburgh. Welcome to the GeriPal podcast, Tim.
Thanks so much for inviting me.
And Tim, we're going to be talking about your New England Journal article about the use of antipsychotics in the management of delirium in the ICU. But before we do that, we always start off with a song suggestion. Do you have a song for Alex?
I do. I'd like to hear Vice Verses by Switchfoot.
Great.
I know that there's a reason to it all. A little resurrection every time I fall. You got your babies, I got my hearses. Every blessing comes with a set of curses. I got my vices, I got my vice verses. I got my vice verses.
Nice.
Yeah, I changed one lyric.
Very nice.
That's why I was reading the lyrics beforehand.
Tim, why did you choose that song?
Well, you know, I when you guys asked me what song I'd like to hear, I wanted to really be clever and come up with one that had to do with delirium, but there just wasn't one that felt right about delirium. And I just ended up choosing one that I thought was really beautiful. I really enjoy the song. And also, as I thought about it, I did think it made sense, given that in the ICU, we're often dealing with tragedy and in some cases with death. And the song is really about how life is full of both the blessings and the curses. And from the beginning to the end, it's all a complete package.
Great. I think it's a great song. I've never heard of that song.
I've never heard that song before, and I love it. And so thank you for introducing us to that song. And it does have some deep, deep meaning, also, as well as that nice drone and the drop D tuning for those of you out there who are guitar players and listening. Check it out. It's fun. It's not too hard to play either.
I also think we have a little bit of a vacuum cleaner in the background that's adding some nice reverb. So let's get started. Let's talk about this. So you just published an article called Haloperidol and Ziprasidone for the treatment of delirium and critical illness in the New England Journal of Medicine in 2018. Before we talk about the article, we always like to ask the authors, how did they get interested in this subject of delirium in ICU patients?
That's a great question. I would say that I've been interested in delirium and in other multiple complications of critical illness since I was a resident. I was fascinated with the critically ill at the time and subsequently ended up going into that field. And delirium was a problem that was very common for critically ill patients, but often was not given much attention. In fact, if you go back a couple decades, it was just labeled ICU psychosis by many and was considered sort of the price of doing business in the ICU. And, to give that line of thinking some credibility at the time, it was thought that the symptoms of delirium would just resolve and had no lasting effect. But a lot of studies have now shown that patients who are delirious during their critical illness, even though the symptoms of delirium almost always resolve prior to discharge from the hospital, there are many adverse long-term effects associated with delirium, including long-term changes in cognition. So I became very interested in studying that. I worked closely with Wes Ely, who's one of the pioneers in this field of study for many years while I was at Vanderbilt, and have continued to focus on delirium and cognitive effects of critical illness after moving to the University of Pittsburgh a couple years ago.
So, Tim, you studied you and this tremendous group across the country. You did this study comparing haloperidol, ziprasidone, and placebo for treatment of delirium. And can you talk a little bit about just the last sort of piece of background from my end is, are antipsychotics as a class prescribed, and Haldol in particular, and and ziprasidone, and why choosing ziprasidone? Maybe starting with the antipsychotics and haloperidol.
Okay, yeah, there are several questions there, so you might have to remind me to cover them all. So first of all, just with antipsychotics in general, antipsychotics, for better or for worse, are very frequently used to treat delirium, whether agitated or not, in the ICU. Now, why is that? I think there are a couple of reasons. One is if you go back and look at the recommendations that were made in clinical practice guidelines as early as the early 90s or certainly in 2002, there were guidelines published by the Society of Critical Care Medicine in 2002 in which haloperidol was recommended as the first-line treatment for delirium in a critically ill patient. Now, you could look at that and say, well, based on the dosing that they recommend, what they're really talking about is agitation. But the bottom line is, if you're looking for a guideline, how do I manage delirium in the ICU? That guideline, which was by far and away the most commonly cited guideline for delirium in the ICU, recommended haloperidol based on no data whatsoever in ICU patients. And they were transparent about that. They weren't claiming that they knew that it worked. They just said, look, this is our best guess based on data primarily outside the ICU in the geriatric literature. And those guidelines, I think, had a major impact because when you look at observational studies, there have been numerous observational studies that show that antipsychotics are frequently given to patients in the ICU.
Yeah, so I had a patient just last week in the ICU, delirious, and had been for, 5 days or so, and met with the ICU team, and they said, we finally started treating his delirium today with haloperidol. And I said, wait a second, didn't a New England Journal Medicine paper just come out about that? It is incredibly common, I think, in our anecdotal experience, and also it was what I was taught.
Right. And what's really interesting is it seems to me that when I look at the data, and certainly I've got my own experience, you've got your experience, we all know what we've seen, but when you actually look at the data that have been published, it's very consistent that you see about 40% in these observational studies, 40% of patients with delirium in the ICU, whether hyperactive or hypoactive, or a mixed picture, received antipsychotics at some point during their ICU stay. And then when you back up and say, well, what if we don't even ask about the delirium patients? Let's just look at all comers to the ICU. There have been a number of studies that have looked at this. And those studies have reported, it's surprising how consistent the numbers are. Multiple studies, not even considering who's delirious and who's not, have found that 11%, so 1 in 10 roughly, of patients who just enter an ICU one day or more in multiple studies receive an antipsychotic at some point. But here's the part that I'm really concerned about. Of those patients who receive an antipsychotic in the ICU, almost all of whom are naive to antipsychotics. They don't come into the ICU on antipsychotics. And some of these studies have specifically excluded patients who were on it prior to their ICU admission. So you look at patients who had never received an antipsychotic, they come into the ICU, they have a 1 in 10 chance of getting an antipsychotic in the ICU, and a quarter of those patients who receive it end up being discharged on an antipsychotic. This has been reported in at least 4 different observational studies from multiple different parts of the world. And you look at that, and there's no way you can attribute that to single dose treatments of agitated delirium, because patients aren't being discharged from the hospital while agitated and delirious. We know that's the case. And yet 25% of patients who received an antipsychotic in the ICU go home on the drug. So there's very clear evidence that we've had mission creep. What started out as a recommendation to do something for a patient who's got agitated delirium in the setting of an acute critical illness has gradually become a scenario where patients who no longer have any symptoms of delirium, agitated or not, are being discharged from the hospital on an antipsychotic. So one of the reasons we wanted to do this, you can talk about all the potential biological hypotheses that might explain why antipsychotics would work or why they might not work. And I think those are important. But even if there was no biological rationale, we were looking at a practice that had become very, very common and yet was not supported by any placebo-controlled trials. There have been multiple small trials done that were all negative. And our thought was, look, we need to know whether or not this has any benefit that we can detect. And if it does, then great. If it doesn't, we need to do a trial that is large enough and convincing enough that will lead to a change in practice. Because if this practice is not beneficial for patients, it needs to stop.
Yeah, and I get the haloperidol, Ziprasidone. I've never prescribed Ziprasidone. I know some people do. How'd you pick that? That was we asked the question on Twitter. What question should we ask you? That was one of the questions that we actually got.
I think it's a really important question, and it relates to the answer to that question is just a little peek into what it takes to do a randomized controlled trial of a drug in the United States. So we went to the FDA, as you need to do when you're going to give a drug off-label in the setting of a randomized trial or via a different route. And in this case, we were doing both, right? Because these drugs are not approved for the treatment of delirium, so it's clearly an off-label use, and they also are not approved as an IV medication for any indication. So it was both a different route and a different indication. So we needed to get approval from the FDA. So we submitted an IND. And another thing that we really wanted to do, in addition to giving it as an intravenous medication, because we think that is the most common way to give antipsychotics, at least initially in the ICU, is we wanted to do this as a double-blind trial. And to do it as a double-blind trial, giving intravenous drugs, you would need to give an intravenous atypical antipsychotic. And the FDA had no reservations. I guess I shouldn't speak for the FDA, but my perception was that they had few reservations about us giving haloperidol because, it's frequently done, even though it's off-label. Been lots of papers published about it. Yeah. But they had some serious concerns about us giving an atypical antipsychotic because there was very little data published on the safety of atypical antipsychotics. Now, I think that's changed in the time since we originally designed this trial. Olanzapine is now more often given as an intravenous drug than it had been at that time. But at the time, they said, look, for us to consider approving a study that includes the use of intravenous atypical antipsychotic, you need to present to us what existing data are available to tell us what the safety might be in humans. And we pulled everything that we could find, and the most of the data were based on Ziprasidone, which is somewhat surprising because, like you said, it's not a drug that we would frequently see used in this setting, and yet that's where we were able to find safety data in humans for an intravenous route of delivery.
And I learned something: Ziprasidone, not Ziprasidone. Is that right?
Oh, you know what? I honestly don't even know which one. You
say Ziprasidone, I say Ziprasidone.
Yeah, it sounds like neither one of us should say. We just shouldn't even start using that word in the ICU at this point. But
so let's jump into the methods. And could you just give us like the 10,000-foot overview of what you did here?
Sure. So in general, this was a randomized double-blind placebo-controlled trial. I think most listeners will be familiar with what that design means. One thing that was a little different about this trial design than many other trials is that we attempted to, and we didn't succeed in every case, but we attempted to identify these patients as early as possible. And in some cases, we tried to identify in every case, but in some cases we succeeded at identifying these patients before they became delirious. And yet the randomization needed to occur when treatment was going to start. And treatment was going to start when the patient became delirious. So we actually had what was called a pre-randomization phase of our research activities. Now that phase wasn't actually part of the clinical trial because the clinical trial starts when randomization occurs and patients are randomly assigned to one of the 3 treatment groups. But we had this pre-randomization period during which we were screening patients, looking for patients who were at high risk for delirium. And we used some pretty simple criteria. If you were mechanically ventilated in the ICU or were in shock on vasopressors in the ICU, then we considered you high risk. Of course, we had some exclusion criteria. We didn't want to include patients who were at high risk for adverse effects. We didn't want to include patients who had severe neurologic injury at baseline. And there are some other exclusion criteria that are outlined in the paper. But we identified these patients sometimes even before they became delirious. They could be not non-delirious because they were comatose and there was no way to assess for whether they were delirious, or they could be non-delirious because they were alert and had normal cognition. And our goal was to identify those patients to obtain informed consent from the patients or their surrogate decision makers as early as possible. For many patients, that was at a time when they were already delirious, and if that was the case, we would just immediately randomize them into one of the 3 treatment groups and start delivering the drug in a double-blind fashion. But for many of the other patients, they were either comatose or had normal cognition at the time that informed consent was obtained, but that didn't mean the trial started then. Instead, we would observe them for up to 5 days, as long as they were still in the ICU. And if at any time during that observation period they did become delirious, that's when the trial would start for them. They would be randomized, and then they would start receiving the treatment, the double-blind study drug.
And so to be included for this study, you had to have delirium based on the CAM, right? You were using the CAM ICU.
The CAM ICU, that's right.
It didn't matter if you were a hypo or hyperactive delirium. Either way, you were enrolled in this study.
That's right. And there are 2 reasons for that. One, 2 reasons for us including both hyper and hypoactive delirium. One was that, and I've already mentioned this data, there are a lot of data that show that patients are getting the drug in both types of delirious states, hypoactive and hyperactive. And then the other is that the largest group of patients in terms of motoric subtype in the ICU are those that have a mixed subtype. So they fluctuate back and forth.
They don't read the manual that you have to either be hyper or hypo.
They don't. That's right. They did not read the DSM.
And like what we said before, even those hypoactive patients, they're still getting it because they're still potentially trying to pull out their lines and their tubes, and they're yet again not reading the manual of what they're supposed to be doing.
Well, I think there's some pushback here. Right? One of my mentees, Pulmonary Critical Care fellow here at UCSF, and he was saying that the UCSF Critical Care Group feels like, well, what if they'd done a study and only patients with agitated, hyperactive delirium might have been effective, because those are the ones who come to our clinical attention the most and who we end up treating the most, as opposed to the hypoactive delirium often sneaks under the radar. It doesn't get treated.
Well, it's really the mix that we see the most, probably, actually. Like these people, think about all the patients that we see with delirium. They're not just hyperactive all the time. They go from hypoactive, usually to start off with some hyperactive.
Mm-hmm.
And like we said, the outcomes are still as bad.
In this conversation about the hypoactive versus hyperactive has really highlighted for me something I would have done different if I were able to rewrite this paper. None of us can look back at a paper and, well, I assume none of us, I guess I can't speak for everyone else. I will say for my own experience, I don't have a single paper I've written that I would look back and say, well, that was perfect. I really got every single thing right.
Right.
And for this paper, I feel like people have really focused on the breakdown of hyperactive and hypoactive in table 1.
Yes.
But what I failed to do as an author, and I guess I can let all my other co-authors share some of the burden for this, or some of the blame. But what we failed to do is to indicate that it wasn't just those 11% who had ever had hyperactive. That was the number who had hyperactive at the time that they were randomized to one of the 3 treatment groups. If you actually look over the course of the full study, it was more than a third. It was pretty close to 40% who developed hyperactive delirium at some point during the trial. Mm-hmm. And that is probably actually even an underestimation of the percent who had delirium at some point. And the reason I say that is that those percentages are based on our twice daily assessments as a research team.
Yeah.
So if, for example, a patient at 11 p.m., when we weren't there at the bedside doing our research assessment, became agitated, and the nurse who was taking care of that patient said, well, this is a concerning situation. We better do something about it. Let's give a little bit more propofol, if that was the sedative patient was receiving at the time. Then by the time we saw the patient again for one of our twice daily assessments in the morning as a research team, we would not have found that the patient was delirious in a hyperactive state.
See, what you needed to do is actually do what all the other previous trials around antipsychotics did, which was don't even mention hypoactive or hyperactive delirium. Because I actually went back to some of the old studies, like that HIV study of like hospitalized HIV patients who got Haldol. The enrollment criteria was like, did they have delirium? It wasn't, did they have hyperactive delirium? Then I looked at some of the atypical studies. Like, nobody enrolled patients with just hyperactive delirium in my very quick review of the literature, which is fascinating that all of a sudden we have this article, I won't jump to results, but potentially shows that it doesn't work. And then people say, oh, no, because they're not hyperactive.
Well,
but we don't even have literature to say that it works in those folks.
Right. I think we should jump to results. Let's jump to results. And we were talking about table 1 here, which is, who was in the study. Do you think that the people in this study are representative of people in ICUs around the country who are A, delirious, and B, delirious and being treated?
Well, I think that they are representative of the sickest patients who are delirious in the ICU. Remember, we only included patients who we considered high risk because they were mechanically ventilated or in shock. And if you look at the percentages, by far and away, the most common reason that you were eligible in this study was because you were mechanically ventilated. But there are a lot of non-mechanically ventilated delirious patients in ICUs across the world that are not really represented in this trial.
Good point.
I guess if you wanted to make an argument that the trial doesn't apply to the non-mechanically ventilated patients who are not in shock, I think that that argument stands. I would respond by saying, well, where are the data that do suggest there's a benefit in that population? Because I'm not aware of the data. And I think at this point, given what we do have in terms of published trials comparing antipsychotics with placebo in the ICU setting, the burden, I believe, is now on those who are using these drugs to say, well, here's the reason, here's the evidence that supports this practice. And it should no longer be the default to give these drugs to delirium, agitated or not, when multiple trials, however imperfect they may be, have yielded no evidence that the drugs help to treat delirium in critical illness.
And just to remind me, so your results, like big picture results that you found, there was no difference in number of days alive without delirium or coma, right? There was no difference in multiple other outcomes, including days of delirium, days with coma, really anything else we looked at, right?
So what I would say, I want to be really careful with my words because it's important to be precise as a researcher. The way I would answer that question is we found no evidence of a difference. Now, does that prove that there's absolutely no difference? No, it doesn't. Remember, what we did was we designed a trial that was powered to detect a 2-day difference in number of days alive without delirium or coma. And that's a mouthful, but really what the primary outcome came down to is how many days did you have normal cognition during the treatment period, right? We treated patients for up to 14 days as long as they were in the ICU during that time. And we measured as our primary outcome the number of days that they had normal cognition. That is, they did not have delirium. They were not comatose. And we powered the trial to detect a 2-day difference. Now, you could say, well, then maybe there was a 1-day difference and you couldn't detect that. And I think that's technically true. I mean, statistically, our data cannot prove that there was not a 0.5-day difference in number of days alive without delirium or coma. That said, if you look at the graphs, it shows you what the estimates are, and it certainly isn't compelling in terms of suggesting maybe there was a difference, but we just weren't powered to detect it.
No, they're not.
I can't, I can't say with any sort of statistical certainty or a statistical test to back me up that there is no difference. All I can say is we found no evidence of a difference.
Did you look at another question from the Twitterverse? Did you look at harmful behavior? Like, did it change, like people pulling out lines or tubes or?
Yeah, so I think that's a really good question. I would say yes and no in terms of did we look at it. No, we didn't look at it directly in the sense that those events are very rare, and we didn't directly observe the patients for 24 hours a day to detect that. It would be difficult to detect it purely by chart review because sometimes when those events occur, they don't end up being documented in the chart.
Yeah.
Certainly a self-extubation is almost always documented, but pulling out an IV is probably almost never documented. Yeah. So it would be hard to detect those kinds of events. However, the reason I would say yes, that we did assess for evidence of those events is that we took very great care to document all of the sedating medications that these patients received, not just the drugs that were given as part of the trial, but also any drug that was given by the treating ICU team that could sedate the patient. We tracked all of that. And then we did a very careful analysis to find out if we could detect any difference in the amount of sedation that patients received. And we also tracked open label antipsychotic use. So, one of the common questions we received is, well, why did you design a trial that allowed patients to receive haloperidol when that was one of the drugs being studied? Well, it's not that our protocol allowed that. It's that we did what is considered the standard of care when you design clinical trials, and that is to do an intention to treat analysis. And so we very much wanted to avoid any open label use of antipsychotics and tried on a consistent daily basis. We would go to these ICU teams. We would remind them every day that this patient is in the trial. Here's what that involves. They should not receive any open label antipsychotics. We even provided the clinicians caring for all the patients that were in this trial with an evidence-based rescue protocol. Now, that was something that they could follow based on their judgment of what was best for the patient, but it wasn't required. In other words, the trial only controlled whether they received one of these 3 drugs, haloperidol, Ziprasidone, or a placebo, which was saline. It did not control whether they received propofol or benzodiazepines or dexmedetomidine or others. But we did have a recommended approach to the treatment of agitation. And the reason we did that, or there were two reasons. One is because we wanted to provide these patients with what we thought was the best available care. And then the second was that we wanted to avoid use of open label antipsychotics. And even with all of those efforts, there were patients who received some open label antipsychotics. The good news is that it was a very small amount, that roughly 20% received at least one dose. But when you look at the overall dose received as open label versus as study drug, it was the open label doses were minuscule compared to the amount
that they received of study drug. Now, this is a question that comes from our Geriatrics Journal Club. The average daily dose of haloperidol was 11, right?
You can go up to 20.
You can go up to 20, but 11 milligrams a day was the average daily dose. And I must admit, I think I was the only person in the room who said they had prescribed doses as high as that the daily, and no one else in the room had. So I'm interested
Bunch of geriatricians.
Right, bunch of geriatricians. Start low, go slow.
This is one of those situations where if you're trying to be all things to all people, you're going to end up disappointing everyone, right? We knew, based on our own experience, as well as talking to many, many intensivists, that there was a very good chance that we would do a randomized controlled trial of antipsychotics and hear from the intensivists at the end of the trial, well, of course it didn't work. You didn't give nearly enough. At the same time, we also knew that the geriatricians would look at us and say, well, of course it didn't work. You gave too much.
Right.
Those doses are dangerous. And so I guess you could argue, well, maybe you should do multiple multi-million-dollar, multi-year randomized controlled trials, some studying low dose, some studying high dose, or you could potentially do a single trial that studied multiple different doses. And I would actually argue that we did in one way do that. We did study multiple different doses in the sense that we didn't have different groups that received different doses, but we had a protocol that started at a low dose for every patient, and then the dose was increased if the patient remained delirious and decreased if the patient was no longer delirious. So our dosing protocol, rather, it titrated the dose according to what the patient's mental status was. And so you could argue, and we started actually at, 5 milligrams. I actually have to look back and remind myself, because we started
depending on age. Yeah, it was like
right. We started at a lower dose for the older patients than we did for the younger patients. But we started at a low dose, and then we increased that dose until they got to the maximum dose, unless their delirium resolved. If it resolved, then we would go back down. So, for those who say, well, these doses seem really high, you could argue that if a lower dose had been effective, we would have seen evidence of that and would not have ended up giving the higher dose.
Mm-hmm. So here's a.
I also think this is fascinating because, I feel like if you used lower doses, folks, and we see this with other trials. Oh, they didn't use enough.
Right, they didn't push it hard and high enough.
Or if you didn't see a difference, folks will say, oh, it's because you didn't use olanzapine or quintiapine. Do you think it would be different if you used different drugs too here? Because, we don't really have any literature that those drugs work any better.
Right. Well, so I should acknowledge that there was one placebo-controlled trial led by John Devlin at Tufts that compared placebo with quetiapine in critically ill patients who had all already received haloperidol. So it was a little bit different of a design. They enrolled patients who were persistently delirious despite receiving haloperidol, and then to that haloperidol, they added either quetiapine or placebo in a double-blind trial. There were 18 patients in each group, and they actually did find in that trial evidence of a benefit. Patients who were treated with quetiapine had an earlier resolution of delirium than patients who were treated with placebo. Now, why is it that we don't all give quetiapine? I think the reason is
because
that
we're
we
using
have
it for sleep for everybody already.
well, maybe so. Maybe so. And in addition to that, we all have had. We certainly in critical care, I think this is probably true of every field of medicine. We have a long track record of early, small, positive, randomized controlled trials that end up not being replicated when larger trials are done. Mm-hmm. So I know John very well, and I think he and I see eye to eye to this. We actually just talked about this again at the European Delirium Association meeting in the Netherlands last month. We both look at those data and say, well, that's really interesting. That certainly suggests that a larger trial should be done, but I don't think either one of us think that that's strong evidence that we should all be giving quetiapine. And why is it that randomized? I'll quickly, as an aside, give a little lesson in interpretation of clinical trials. Why is it that a small trial is less likely to be replicated? Well, because the smaller the trial, the less likely randomization is to end up resulting in evenly distributed groups. And even if you look at table 1 in that trial, you see that patients in the placebo group there were a higher percentage of patients that came from nursing homes. They were a little older. So right. You have 18 patients in each group, and they might not be the same.
Yeah, it's small.
And I'm also looking that you did not have to have just hyperactive delirium for that study too.
No, you did not.
No, well, let's stick with the hyperactive. I know that in this study, at the time of randomization, we're talking small numbers who had hyperactive delirium. But as you just said, at some point during the study, of those enrolled, something like 40%. Had evidence of hyperactive delirium. Did you do a subgroup analysis in those patients?
So what we did to analyze the effect on hyperactive delirium is that we measured delirium every day in every patient, and we measured whether that delirium was hyperactive or hypoactive. And as I said earlier, that was at the time that our research staff were assessing these patients. So it didn't necessarily detect all hyperactive delirium, but using those data, we were able to compare not only the overall duration of delirium in the two groups, or as I said earlier, the primary outcome was the number of days without delirium and coma. So we could compare that, but we also were able to analyze whether the duration of hyperactive delirium and the duration of hypoactive delirium were different. So that's not exactly the same as doing a subgroup analysis where you sort of just section off all the patients who ever had hyperactive delirium and all the patients who ever had hypoactive delirium. Instead, we did it this way because, as we've mentioned several times, patients can fluctuate. They can be hyperactive at one point and hypoactive at the other. So if you did a subgroup analysis, how would you know which of the two groups to put the patient in if they had mixed delirium? I guess you could do a third group that was just mixed. But instead, what we did was we compared duration of hyperactive delirium between the three groups, and we compared the duration of hypoactive delirium between the three groups. And in both of those analyses, we found no evidence of any difference.
All right, so my two last questions. The first question is, does this change your practice? And if so, like, how do you manage hyperactive, or how do you manage ICU delirium?
Yeah, great question.
Yeah, so those are two different questions. The answer to the first
I got three questions for you then.
Does this change my practice? I don't think that it does, because I had in 2010 we published the pilot trial that we ended up using to obtain the funding to do this larger trial. And in that pilot trial, admittedly a small trial, it's really only designed to show that it was feasible to do a double-blind placebo-controlled trial of this condition with these drugs. But in that pilot trial, there was really no evidence of a difference. And at that time, I certainly was not convinced that there was no difference, but I just felt, well, unless there's a strong reason to believe that these drugs work, I think I'll focus on another approach.
So your practice didn't change because you weren't doing it. Well, I'm gonna save my two questions because I'm gonna bring back my first question is, how do you convince others that their current practice should change based on this study then?
Yeah. So
how do you convince other ICU doctors that, because Alex is looking at, I'm confusing him. How do you convince other ICU doctors that they should change their practice, or should we based on this study?
I think that it should change their practice. And my major concern is that patients who are started on a drug, even with good intentions in the ICU, end up at risk for being discharged on that drug. Now, you can easily say, well, that's a problem with medication reconciliation and a problem with transitions of care, and that's all true. But the bottom line is that we in the ICU we need to think about the ways that what we're doing affect patients not only in that moment at that time that we're writing the prescription to start an antipsychotic, but we also need to recognize that it may have effects down the line. And 25% seems like an awfully high percentage to me of patients who I started on an antipsychotic in the ICU with good intentions, but now are going home on a drug that has a black box warning from the FDA when used as an outpatient medication. So I feel like if I had strong evidence or even medium quality evidence that it was beneficial in the ICU, that would be enough reason to start it.
Okay, I'm going to use up my last question here. And this is a question we should always ask. What would they do in Canada? And my understanding from our journal club is in Canada, they feel like, hey, we're not going to be able to treat this delirium, but this patient is agitated and pulling out whatever. We're going to sedate them. And that's what happens when you get to high doses of antipsychotics, right? You're really using them more for the sedative effect. So then rather than giving an antipsychotic, they give a sedative. And they give a mild one like trazodone or trazodone. Trazodone?
Dang, those A's.
Yeah, so, well, I guess that gets back to the question of how do I manage delirium? And I don't think there's one easy answer because every patient with delirium is a little bit different than the last. But for one, I try to do consistently across the board the ABCDF bundle. And we probably don't have time at the end of the podcast to go through every one of the components of that bundle, but it's very easy to look it up. If you Google ABCDEF bundle, you will find multiple websites with information about that. That is an approach to care that has components that have consistently been shown to improve outcomes for patients who are critically ill. And when packaged together and delivered consistently, a number of studies have suggested that it reduces delirium. Now, does it necessarily treat agitation? Not necessarily, but it does look like it improves cognition, reduces delirium overall. How would I treat agitation in the setting of a critical illness? Typically, I would sedate the patient. Now, that's assuming that this was agitation that I thought was truly dangerous to the patient. I will say in my own personal experience that I have come across many, many patients over the years that one person on the ICU team may think is having very dangerous agitation. But when I assess the patient, I think, okay, it's not ideal that they're agitated, but they're not actually pulling out lines or disrupting care. It's just uncomfortable to see them in this state. And I think we have to acknowledge that many times we're giving medications, whether it's antipsychotics or other medications that will sedate the patient, because it's just not pleasant to see them squirming in bed. And I certainly don't want that for my patients. But you have to ask, well, is the alternative, which is sedating them sometimes to the point of drug-induced coma, better? And most of the data suggests that it's actually not better to use heavy sedation, even if it's prompted by agitation. So if a patient is exhibiting agitation to the point that it's dangerous, then yes, I would use sedation. If they were not mechanically ventilated, then I would use a sedative that doesn't suppress respiratory drive. And IV haloperidol would be one that I consider, specifically because it may help with agitation and it would do so without suppressing respiratory drive. More often than that, though, I would consider dexmedetomidine.
Okay.
Oh, okay, dexmedetomidine. I wonder, though, is there a possibility that an unintended consequence of the study is there'll be an increased use of restraints? Physical restraint rather than a chemical.
Yeah, I hope that that's not the case. I'm definitely not a fan. I would recommend against using restraints unless absolutely necessary. Yeah. My experience is that there are a lot of ICUs and hospitals where culturally the norm is to use restraints and to sort of justify it as a chemical, as an alternative to chemical restraints. But when you actually look under the hood, what you see is that they're doing both. So right. That's problematic.
Well, I want to thank you tremendously for actually joining us on this podcast.
Thank you so much,
learned
Tim.
a ton.
Yes.
And
kudos to you for this is a tremendous amount of work, we have to say.
Yeah,
a tremendous amount of work. Kudos to you. Kudos to the team based at Vanderbilt and the 16 centers around the country. Amazing.
Yeah, thank you very much.
Yeah,
thanks. And I really appreciated being on the podcast. You guys do a great job. I find these podcasts really helpful, and I know a lot of others do.
Well, we're going to end a little bit with Alex singing. What's the song called again?
Vice Verses by Switchfoot. Walking along the high tide line, watching the Pacific from the sidelines, wondering what it means to live together, looking for more than just guidelines, looking for signs in the night sky, wishing I wasn't such a nice guy, wondering what it means to live together, wondering what it means to die. I know that there's a meaning to it all, a little resurrection every time I fall. You got your babies, I got my hearses, every person has got a set of curses. I got my vices, I got my vice verses, I got my vice verses.
And with that, I want to thank all of our listeners for joining us today. We look forward to having you with us next week for our next podcast. And again, big thank you, Tim, for joining us.
Thanks, Tim.
Thank you. I really enjoyed it.